Hi, this is Mrs. Lewicki, and this is part 2 of the endocrine presentations. This is thyroid and diabetic concerns. Thyroid hormones regulate the basal metabolic rate and lipid and carbohydrate metabolism. They're essential for normal growth and development and control the heat regulation. So occasionally we have an underproduction of a thyroid or an overproduction. So primary hypothyroidism stems from an abnormality in the thyroid gland itself and occurs when the thyroid gland is not able to perform its functions, such as releasing the thyroid hormones from their storage sites, coupling iodine with tyrosine, trapping iodide, or converting iodide to iodine. Secondary hypothyroidism results from reduced secretion of thyroid stimulating hormone. Tertiary hypothyroidism is caused by a reduced level of the thyrotropin releasing hormone from the hypothalamus system, thermoregulatory center in the brain, and have various effects on the cardiovascular, endocrine, and neuromuscular system. Three main disorders include cretinism, hyposecretion of the thyroid hormone during youth myxedemia, hyposecretion of thyroid hormone during adulthood, goiter, and enlargement of the thyroid gland. Symptoms of hypothyroidism include cold intolerance, unintentional weight gain, depression, dry, brittle hair and nails, fatigue. Diseases known to cause hyperthyroidism include Graves' disease, Plummer's, and multinodal diseases and thyroid storm. Hyperthyroidism can affect multiple body systems, resulting in an overall increase in metabolism. Common symptoms are diarrhea, flushing, increased appetite, muscle weakness, fatigue, palpitations, irritability, nervousness, sleep disorders, heat intolerance, and altered menstrual flow. So one of the main medications that we use to replace thyroid hormones is a synthetic thyroid replacement, and it's called Synthroid or levothyroxine. Levothyroxine is the generic name, and that's the one you need to know. Used in hypothyroidism. Side effects can be cardiac dysrhythmias. Interventions, it's given just once a day orally. Normally, it's ordered, it should be about a half to an hour before breakfast. It can also be given IV if the patient is NPO for a prolonged period of time. We want to monitor the thyroid function levels, which means that the patient will probably have to go every 3 to 6 months to monitor their T3 and T4 levels. For hyperthyroidism, what we want to do is inhibit the incorporation of iodine molecules into amino acid tyrosine. Used in Graves' disease, multinodular disease, Plummer's disease, and thyroid storm. Meds include pethimazole and propylthiouracil. Sorry, I'm having trouble saying all this. They may try to use some radioactive iodine, I-131. It works by destroying the thyroid gland. They may have surgery to remove all or part of the thyroid gland, and if that happens, then they need to be on the Synthroid. And they may try drug therapy, which is what I just said. If patients are on propylthiouracil or methimazole, we need to make sure that they avoid foods high in iodine, such as soy, tofu, and seafood. And side effects is they can cause liver and bone toxicity. So we're going to talk about diabetic drugs. Just a general overview is diabetics can be type 1 or type 2, and we'll talk about those in just a minute. We're concerned about hyperglycemia and hypoglycemia. And for hyperglycemia or an elevated blood sugar, it's the 3 Ps: polyuria, polydipsia, polyphagia. as well as they might have glycosuria, which is glucose in their urine, unexplained weight loss, fatigue, and blurred vision. When monitoring a patient who is diabetic, we do closely monitor their hemoglobin A1C. The other name for that is glycosylated hemoglobin. The reason that we look at that is the glucose molecule binds to the hemoglobin over time, and what the glycosylated hemoglobin, or the A1C, can tell the healthcare provider is how compliant or what the average blood glucose level has been over the last 2 or 3 months. Just an overview again, type 1 diabetes is usually juvenile onset, under 20 years old. They're usually dependent on insulin because they really don't make any insulin anymore. So they're usually thin or non-obese, and treatment is with insulin. Type 2 diabetes are 90% of the cases, and that seems to have gone up over the years as the baby boomers have aged. It previously was a mature onset, but because our diets have changed so much, or at least that's what they say, we're seeing younger people, younger and younger, get type 2 diabetes. They do make their own insulin, and so meds are targeted in helping utilize what's made a little better. And what happens is that there's a problem with the insulin receptor. They're not working as well. Most of the time, 80% of the time, type 2 diabetics are obese. And treatment is usually lifestyle changes such as weight loss and diet and exercise, and starts with oral hypoglycemics, although there are a lot of new meds on the market. So they found that the earlier introduction of an insulin or insulin type medication, the better the outcome for the patients. Treatment for diabetes type 1 is going to be insulin, and type 2, we talked about this already. The goal is to have the patient have a normal glucose level, and if the patient is symptomatic at all and are not sure whether they're hypoglycemic or hyperglycemic, it's better to err on the hypoglycemia side and give a treatment for that. There are a lot of newer insulins that are long-acting, so what that means is they have no peak time. Lantus and Levemir are 2 of those, and they don't have a peak time, and they last for 24 hours. So there are all kinds of types. Humulog or Novolog is a rapid-acting insulin. It peaks, or the onset of action is 15 minutes. The peak time is 1 to 2 hours. Duration of action is 3 to 5 hours. Regular insulin is 30 to 60 minutes with a peak concentration of 2.5 hours, and duration is 6 to 10 hours. Now, both of those insulins are clear, where NPH insulin is a cloudy insulin, and it's a intermediate acting is what it's considered now. Onset is within 1 to 2 hours. Peak concentration is 4 to 8 hours. Duration of action is 10 to 18 hours. There are all kinds of combinations of these insulins, like a 70-30 or a 90-10 or a 60-40. And if you don't have that, and some patients now will still be on NPH insulin in the morning and at bedtime or at supper time, and it's important to understand the peak concentration and the onset of action so that you know when they're having hypoglycemic events what might be the cause of that, or you can predict it based on when they had their insulins. One of the earliest oral anti-diabetic agent is a bigonide, which would be metformin. It decreases glucose production in the liver. It's the first class of drugs, especially for patients with a BMI over 25, and the most commonly used oral drug for type 2 diabetes. Side effects: abdominal bloating, nausea, cramping, diarrhea. They say that the diarrhea usually resolves. It doesn't always, and you can try lower doses. A lot of times the GI upset is too severe, and so people need to come off of this med. Contraindicated in patients with hepatic, renal, cardiopulmonary disease, and alcoholism. Needs to be taken with food and to reduce GI upset. If somebody's going for a CT scan with contrast or an MRI with contrast or any type of contrast, the metformin has to be held for 48 hours prior to that. And that has to do with it can cause renal failure if the contrast is not properly flushed from the system. Sulfonylureas bind with beta receptors in the pancreas to stimulate the release of insulin. It's the second step in patients with high hemoglobin A1Cs that are on metformin. It has a rapid onset and short duration of action, so you could take it in the morning and evening. Glyburide, glucotrol, and glimepiride are a couple of the names. Side effects: weight gain, nausea, hypoglycemia. Interventions are to give in the morning, 30 minutes before breakfast. If it's in the evening, it's before the evening meal. Glynides increase the secretion of insulin in the pancreas. They have a much shorter duration of action, so are often given in combination with other anti-diabetic meds or for patients who have erratic meal patterns, as they only take them when they eat. Some of those are reglanide and nataglinide. Side effects: weight gain. Intervention is it is taken with meals. There are 3 categories of anti-diabetic meds. Newer categories, that we don't actually talk about in here, and they're used when the other meds do not work. Hypoglycemia. This is an important thing that we have to watch for. As I said earlier, in this case, blood sugar is less than 50. Can be an adverse effect of anti-diabetic medications. Treatment is fruit juice, honey, or a non-diet soda. Oral concentration of glucose, buccal tablets, oral high concentration. And that would be something that they would dissolve in their cheek. Sub-Q glucagon, or if severe or they're hospitalized, we would give D50, or just dextrose 50. That's the end of this PowerPoint.